Hello, everybody. Welcome to another edition of AFR's EMS Case Studies. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire. Today, we're joined by our Medical Director, Dr. Kim Pruitt.
Hi, Chief.
And we're joined by Captain Kyle Christian.
Afternoon, Chief.
So, never a shortage of incredible calls that you bring our way. I think you're somewhat of a black cloud, but we have two call types that obviously are high acuity and kind of low frequency, and those are like SVT cases and then cases with patients who are pregnant, and you're going to bring us a case that has both of those. So super interesting. We had Rescue 16, Engine 16, and you were dispatched to a 10 Delta for the report of chest pain and palpitations. You kind of told us you were just a block away clearing another call, so not a lot of information before you made patient contact.
Right.
So when you guys get that call, you're right around the corner, you're pretty much on top of it. Tell me what you see when you walk through the door.
Sure. So we kind of like you were just saying, we wouldn't say got blindsided by this call. We didn't have we definitely didn't have the benefit of hearing the dispatch come out. We didn't have the benefit of getting a lot of time to read any dispatcher comments. We had just cleared our engine crew from another call at a skilled nurse facility about a block away. And then when I turned over the other patient to Albuquerque ambulance, we saw flashing lights across the parking lot, and I thought, is the engine on something? And went to look, and sure enough, they were on 10 Delta, and we got put on it kind of right as we were rolling up on scene. We walked in, the engine company had been there for maybe 5 minutes or so, not too long, but enough to get an initial set of vitals. We're heads up enough to put this patient on the monitor right away. And I think a lot of that owed to the fact that when they put the pulse ox on the patient, they saw 200 on the pulse ox for a heart rate. But essentially, we walked in, and it was female in her late 20s, known history of SVT, 32 weeks pregnant, and essentially was having heart palpitations and some anxiety associated with that. Was essentially just kind of leaned up against some pillows with her partner, kneeled behind her, kind of holding her up. Very tachypnic, very anxious, kind of speaking in one or two word sentences, so it was impressive that the engine officer had even gotten a real full history on her. But relatively stable. We had the benefit of having that first set of vitals already completed for us when the rescue rolled in. So we kind of just got to get right down to brass tacks and kind of just get right down to treatment and trying to improve the situation.
So that initial rate they got on the pulse ox, you said it was in the 220s. They got her on the monitor, and I'm assuming it matched.
It did, yeah. So it was definitely an SVT like we were assuming it was. She had a history of, and it was an SVT with very little space between those QRS segments. So without counting it out, I believed it right away.
And we were at 32 weeks gestation. Any issues with the pregnancy that she elicited to you all?
No. I want to say, I can't remember if she said this was her first or her second, but she was, we had the benefit of asking her, did this happen in your previous pregnancy? She said no. No complications with her past pregnancy, no complications with this pregnancy thus far. She specifically said no preeclampsia or eclampsia reported from her previous pregnancies. That was kind of one of our initial worries. She said everything had been smooth sailing up until this point. So
she's alert and oriented. She's talking to you full sentences, kind of like you talked about her. It's a little bit tachypnic, but
a little broken,
able to track and everything. So initial vitals, it looks like 125 over 101, so a little bit of a high diastolic rate. 98% on the room air. She's breathing about 22 times a minute. What was your first steps in terms of treating the SVT?
Sure. So we, fortunately, she was able to answer us, at least somewhat. So we asked her, when you had previous occurrences of this, how did it resolve? Did it end up, were vagal maneuvers effective? Did you end up needing to get the medication, or did they need to give you electricity? It was kind of how we phrased it to her. And she said that the vagal maneuvers never work. They keep having her hold her breath, and it just ends up making her lightheaded, and it almost makes her more anxious, I can imagine. But she said the medication usually works, and it usually only takes one dose. So she was very specific, knew more than most people know about their condition in that case. So we were thankful for that. So our immediate thought was, okay, let's get ready to use adenosine. Definitely not in an unstable condition, but she's probably not going to be feeling too hot, with a heart rate in the 220s for too long. So.
Yeah, absolutely. And I think we encounter that too. The patients have a history of SVT. They're usually your best historians to tell you exactly what works and what doesn't. So that's always a benefit to us. Doc, how prevalent is episodes of SVT when you're dealing with a population of women who are pregnant? Do you see that often?
So thankfully, it's not super prevalent in the population, but there is an increased incidence of SVT occurring, particularly in the third trimester. The reasoning being that you have kind of already a hyperdynamic circulation. As that uterus starts to expand, the baby gets bigger. The physiologic changes that happen in pregnancy can include like increased hormones. You have a higher circulating blood volume, which can lead to atrial stretch, which can change that sinoatrial node a little bit and that conduction there. Increased catecholamines. And so there's a lot of physiologic changes that happen in pregnancy that can preclude ladies, especially ones that are already prone to it at baseline, to have more incidences of SVT, especially in that third trimester.
So not just patients with diagnosed SVT throughout their life, but it's potential that they could have it, just new onset.
New onset, that's correct. With all the physiologic changes that are going on, it wouldn't be surprising to have it. Thankfully, it's still pretty rare, but if it's going to happen, it's not uncommon in that third trimester.
In terms of practice, I know the patient made mention that the Valsalva maneuvers typically didn't work for her. Did you guys make an attempt at that?
We did. So it just because of the pacing, the timing of the scene, it takes a couple minutes to kind of find that vein, get that vascular access. Maybe get some fluids, get a bag spike to kind of get prepared in case this were to turn into something. Am I trying to say something more serious, a little more acute? Thank you. So we did try some Valsalva maneuvers. We ended up doing the blow through a plunger in a syringe. Kind of gave her I can't remember what it was, a 5 mil plunger, and kind of had her try to blow on that. We did put her on some oxygen. We gave her on a Capno cannula, and we're just kind of continuing to monitor, make sure this kind of didn't turn more symptomatic than it currently was.
Excellent. Is there a specific position, Doc, that we can place these patients in while we're preparing those Valsalva maneuvers? As far as a pregnant patient, is there a way that we can position them to kind of help our cause?
I think with her, it sounds like you're still on scene and she was still propped up, so I think it's fine. But if you find yourself transporting with her on a gurney, always in that third trimester, it's a good idea if you can to kind of prop up that left side, just to the weight of the uterus can decrease the blood flow return to the heart through the inferior vena cava. And so by tilting them a little bit to the patient's left, you can allow more blood return to the heart that way. It sounds like in this case you didn't necessarily need to do that, but it's something good to consider if you find yourself with a gravid patient on a stretcher.
And we had it was a low end tidal volume is what we got initially, our low end tidal reading, and that's why we gave that supplemental oxygen as well. You guys started the peripheral IV, and then the next line was the adenosine. Is that what the plan was?
The next time was going to be the adenosine. So we gave her not too much of a fluid challenge, kind of like we were talking about before. That blood pressure looked pretty good. She'd kind of reported that she had more or less had a normal day, normal oral intake, plenty of fluids, especially being in her third trimester of pregnancy. So we weren't too worried about her kind of being dehydrated or really needing a large fluid challenge. We kind of felt like the adenosine was just going to be, if it's what helped her before, it more than likely was kind of where we were headed with this one. So we kind of wanted to be prepared and just have that in the workings while we were trying to get some comfort care going there.
All right, so we gave that first round of 6 milligrams of adenosine, and what happened?
It took so long for a conversion, and we were all staring expectantly at her face, and nothing happened for quite a while, actually, which wasn't surprising because she had told us, I misspoke earlier, she had told us that it usually took 2 doses to convert her. Usually it was a little more stubborn. It did take that second dose to actually resolve the SVT. So we didn't see a change. She didn't become any more uncomfortable. She usually kind of see that look in their eyes where, like I have a heavy feeling in my chest and nothing. So we were getting ready with that second dose when we looked over at the monitor and we started to see a change. A very, very brief asystolic period there, followed by essentially runs of VTAC, kind of bordering on a torsades even, where we would have a run of VTAC and almost kind of an AFib, irregular PAC-looking kind of rhythm, and then right back into a run of VTAC, and finally it ended in a nice sustained sinus tachycardia, but it took a little while both before it happened and while it was happening. We were kind of staring at the monitor thinking that she should look worse than she does, and she kind of kept looking at us like, what's happening, you know? So it was,
So
it
no
was good.
physical presentation that correlated with that. It was just the monitor, you're watching it, you're kind of like,
Right.
what's going to happen? But she was otherwise stable still.
She felt very stable. She continued talking to us. We kind of were, keeping her talking just conversationally. She was already feeling heart palpitations. I can imagine those heart palpitations may have kind of increased during some of the cardiac activity we saw on the monitor, but she didn't vocalize anything about that. She took it very, very well, actually.
Doc, for the pregnant patient, obviously adenosine is still the first line intervention. And what about electricity? Because all of us would be we're a little worried, right? It makes us a
Yeah.
little nervous to introduce electricity with a pregnant patient. What are your thoughts on that and how do we proceed?
So I like your stepwise process here. Adenosine is safe in pregnancy. It's actually the recommended first-line treatment, so it's safe to give here. And actually, if you can chemically convert, it's a little better than having to use electricity. But that is the question in everybody's mind: can I do this? Will it cause harm? And the truth is, there's been some studies that show electrical cardioversion in an unstable patient, if she had become unstable, is okay. It is just as effective as it is in the general population. It's not shown to cause any harm to the fetus. And the way I like to think of it is you have to save the baby, you have to save mom. And you got to get mom stable as quickly as you can in order to keep the perfusion going to that uterus and to that baby. And so if indicated, if her blood pressure had dropped or she had gone into a sustained unstable rhythm, then cardioversion would have been indicated. The only studies that I saw, and thankfully this is not very common, there were case studies of maybe 50 cases before, and the only outcome they saw in a couple of the cases that there's a small risk of preterm labor. But it's usually well-tolerated electrical cardioversion in all 3 trimesters of pregnancy.
Interesting. So thankfully, we didn't have to get to that step in this
Right.
case. So we had the conversion. Sounds like went to a sinus tac rhythm. Did she feel more comfortable?
She felt much more comfortable. She truly started speaking in full sentences. I think she didn't realize how foreign this presentation was for us and how much a lot of the ALS providers on scene were kind of sweating, pushing this medication and considering electricity. I had never encountered this specific patient presentation, and neither had any of the rest of the crew. So she thought, all's well that ends well, but we were all sweating a little bit on the inside there, so
I
she
bet.
looked much better.
Rescue 16 participate in the transport, or Albuquerque ambulance able to do it on their own without any additional assistance?
So Albuquerque ambulance ended up doing it on their own. She was, still in completely stable condition by the time we transferred her over. She walked to the gurney. I want to say at her own request, even. She was adamant, just get my purse. I'll get on the gurney. They checked another set of vitals. We kind of got a secondary 12 lead when we got in the back. I think on Albuquerque ambulance's monitor, we swapped the monitors and swapped the cables, and then they were on their way.
Do you recall where we went, where the destination was for the patient?
Ooh, for some reason, I think we actually did do women's. I think Loveless sounds right for this one, which was fortunate right down the road there. So we kind of,
And that was kind of part of my next question, because I wasn't sure exactly where we went, but just in terms of like two different issues going here, right? With the patient and that population being so close to her gestational period, are we going down to a cardiac capable facility, or are we going more towards the pregnancy care?
I feel like Loveless, at least women's, would have been an appropriate destination here, because if she had the highest risk thing would be if we put her into labor and she delivered. They do have a NICU. They are a NICU capable facility. The ER can handle SVT probably just as good as any cardiac cath lab capable hospital could. And so I think from a cardiac standpoint, any ER would be fine. From the pregnancy standpoint, with a potential preterm delivery, Loveless does have a NICU, as does UNM and Press Downtown. So I think either of those 3 would have been really good options there.
Good call. All right. Outstanding case, super interesting. Any takeaways that you would want to share with somebody who, I don't know how, but would encounter the same situation in the future?
So hopefully nobody sees this specific patient again, or this patient presentation again. But it was interesting. And I think the biggest thing that we talked about afterwards was it was fortunate that we had someone kind of with that global view on the scene that was able to check protocols for us. I was joking with the doc that I had a syringe of adenosine in my hand and was putting it on the needleless port right as I kind of went, is this safe to do? Like it kind of like it finally just clicked with me. Like, am I okay to do this? Is there anything in the formulary that says not to do this? We encounter SVT not regularly, but semi-regularly enough where a lot of our providers on the streets have administered this medication and kind of know that brief pause that scares us more than the patients, where there's some big changes on that monitor. I really thought, is this going to be harmful to the baby, what I'm about to do with the electrical activity in mom's heart? And fortunately not. I kind of got the thumbs up from the formulary and from my fellow provider after the med cross check, and we continued on like we normally would. But there was definitely a pause there.
Yeah. No, absolutely. It's understandable. That's great. That's exactly what the guidelines are for, is to be able to review that and taking that step to make sure, 100%. I think it was great doing this podcast today to be able to discuss that, because I think if you ever do encounter that, the electricity is safe, right? Taking care of mom before you can take care of baby is kind of the biggest takeaway for me. So fantastic job by you and your crew that day.
Thank you.
That's all we have for this case. If anybody has any interesting cases they want to share, they can use the SharePoint tab, or they can reach out to anybody from the EMS division. Come down and talk about a cool case. Until then, we'll see you next time.